Hello, my name is Amit Kilic, and the topic we'd like to discuss today for the TSDA Curriculum Lecture Series is Penetrating Aortic Ulcers. Currently, a great deal of confusion and controversy surrounds this topic. It is our intention that this talk will demystify some of these key issues. Penetrating aortic ulcers are part of a constellation of disorders known as acute aortic syndromes. Acute aortic syndromes represent a spectrum of disease processes such as an aortic dissection, an intramural hematoma, aortic rupture, traumatic aortic transection, and our topic at hand, penetrating atherosclerotic ulcer of the aorta. First, before discussing penetrating aortic ulcers, it is useful to define the anatomy of the aorta. The aorta is comprised of three layers. The innermost layer is called the intima, the middle layer is called the media, and the outermost layer is termed the adventitia. With this knowledge, we will discuss and differentiate the three major reasons for acute aortic syndromes: aortic dissection, intramural hematoma, and a penetrating aortic ulcer. By far, the most common cause of an acute aortic syndrome is an aortic dissection. A dissection occurs with a tear of the innermost or intimal layer of the aorta. This can be seen on the diagram to the far left. Subsequently, the pulsation and pressure of the aorta leads to a continuation and propagation of this tear, as seen in the middle diagram. This can lead to both an antegrade and retrograde dissection, giving it the characteristic double barrel sign as demonstrated on the short axis view on the bottom right. An intramural hematoma, in contrast, is an aortic process that spares the intimal layer of the aorta. It occurs as a result of a rupture of the vasa vasorum into the medial layer of the aorta. This is depicted on the figures on the left and in the middle. This leads to a separation of the layers of the media and can cause compression of the true lumen of the aorta, as depicted on the picture on the bottom right. Please note that there is no intimal disruption in this disease process. A penetrating aortic ulcer has components of both an intramural hematoma as well as an aortic dissection. This has led some to believe that these three syndromes may be a natural progression of the same disease process. Others, however, disagree. And as a consequence, much of the confusion regarding their terminology and classification has risen. The penetrating aortic ulcer is usually secondary to an atherosclerotic plaque, which leads to a deep ulceration causing an intimal tear. This is depicted in the picture on the left and in the middle. Subsequently, as a result of this tear, blood can enter into the medial layer, as seen on bottom right. This can cause an intramural hematoma that is often seen accompanying a penetrating aortic ulcer. The first to define a penetrating aortic ulcer was Shannon. In 1934, he reviewed over 300 patients post-mortem with dissecting aneurysms and detailed the findings and identification of a penetrating aortic ulcer at autopsy. Roughly 50 years later, Stanson further characterized the lesion as a penetration of the internal elastic lamina and the resultant hematoma formation of the aortic wall. It is estimated that an acute aortic syndrome will affect roughly 2.5% of the general population. Of this, a penetrating aortic ulcer makes up anywhere between 2 to 8% of that group. This entity is often seen in the elderly, with a peak in incidence between the 6th and 8th decades of life. Although rare, multiple penetrating aortic ulcers can be found in roughly 1/5 of all such patients. The most commonly affected segment of the aorta is the descending thoracic aorta, followed by the arch of the aorta, then the infrarenal abdominal aorta, with the least likely area of finding a penetrating aortic ulcer being the ascending aorta. The most common risk factors for the development of an aortic ulcer are listed on this slide. By far the most frequent associated finding is hypertension. This is found in well over 90% of all patients. Smoking, chronic obstructive pulmonary disease, diabetes mellitus, and other evidence of atherosclerotic disease are all risk factors, but not nearly to the degree as high blood pressure. The majority of penetrating aortic ulcers are asymptomatic. The reason for the recent resurgence of interest in penetrating aortic ulcers has been the increasing frequency with which they are being identified on modern high-quality imaging modalities. That being said, the classic symptoms associated with a penetrating ulcer are that of sharp pain. It is described as a tearing, throbbing, sudden pain, much like that associated with an acute aortic dissection. The location of the pain correlates with the location of the ulcer. Anterior chest pain with ulcers of the ascending aorta, interscapular or back pain with lesions involving the descending aorta, and back pain or abdominal pain with ulcers involving the abdominal aorta. The table on this slide, which is taken from the literature on acute aortic dissection, illustrates the nature of the pain with acute aortic syndromes. These findings from the International Registry on Acute Aortic Dissection highlight the ubiquitous nature of pain as being the presenting symptom. In addition, it highlights the intensity of the pain that is felt by the patient. It may be more useful then to highlight the differences in presentation between patients with penetrating aortic ulcers and patients with aortic dissections. This table by Cody et al. Illustrates this point quite nicely. The typical patient with a penetrating aortic ulcer is an elderly patient with a median age in the 70s and suffering from high blood pressure. Although the finding of pain is common in both entities, the absence of any pulse deficits or any signs of malperfusion is seen with a penetrating aortic ulcer. The pathophysiology of an intimal tear with a resultant flap is key for the aortic dissection, as opposed to a more focal area of intimal tear with no false lumen propagation and a well-localized process as that seen in the penetrating aortic ulcer. In addition, the penetrating aortic ulcer is associated with severe atherosclerotic changes seen elsewhere in the aorta. This is in distinct opposition to the variable association of aortic ulcers seen with aortic dissections. The diagnosis, especially in asymptomatic patients of aortic ulcers, is clinched largely on imaging modality. In the modern era of imaging, the overwhelming majority of patients are diagnosed via computed tomography angiography. However, it is useful to familiarize oneself with the characteristic findings of aortic ulcers on the various imaging modalities. A significant proportion of penetrating aortic ulcers can be picked up on aortograms, magnetic resonance angiograms, and transesophageal echocardiograms, since most of these lesions are picked up as incidentalomas. These images, taken from a 58-year-old woman with severe back pain as her chief complaint, highlight the pathophysiology of a penetrating aortic ulcer. In the upper panel, an unenhanced CT scan is shown. The solid arrow highlights an area of high attenuation that is associated with an intramural hematoma. The bottom panel, a contrast-enhanced CT scan at the same level of the distal thoracic aorta as the above panel, shows a penetrating aortic ulcer. There is contrast within the ulcer as highlighted by the empty arrow. In this image, the intramural hematoma can be seen as an area of low attenuation and thickening of the aorta. In comparison, a lateral arteriography from the same patient illustrates the atherosclerotic ulcer and how it can be identified on arteriography. In the sagittal view of a reformatted CT scan, the ulcer can be seen with the empty arrow as well as the surrounding intramural hematoma that is highlighted by the solid arrows. This slide nicely represents the differences that can be seen in a penetrating ulcer in different imaging modalities. Although the vast majority of penetrating aortic ulcers occur in the descending thoracic aorta, anywhere between 7 to 20% of all penetrating aortic ulcers are found proximal to the left subclavian artery. These images are taken from a 71-year-old female with a history of hypertension who presented with retrosternal chest pain. The image on the left is an enhanced CT scan of her chest, highlighting her ascending aorta. The arrow illustrates an outpouching of the aorta without an associated flap, leading to the diagnosis of a penetrating aortic ulcer. The image on the right is an intraoperative picture of the lesion. Note that the head of the patient is to the bottom right of the screen, with the proximal ascending aorta on the upper left. With the help of a retractor, the penetrating aortic ulcer can be seen in the posterior wall of the aorta, as highlighted by the arrow. These three CT scans are taken from a 61-year-old with severe chest and back pain. All three scans represent different phases of contrast from the same axial level and serve to highlight the diagnosis. In panel A, an unenhanced view is seen. The asterisk represents an acute intramural hematoma. Note the hyperdense nature of this process. In panel B, the middle panel, an arterial phase of the CT scan is shown. Once again, note the asterisk highlighting the hematoma. In addition, white solid arrows show evidence of hematoma formation of the surrounding tissue, with the penetrating aortic ulcer being highlighted by a solid white triangular arrowhead. In addition, note solid black triangular arrowheads which show two areas of calcification around the aortic arch and at the base of this ulcer. In panel C, the portovenous phase of the same process can be seen, but with different levels of enhancement. The typical appearance of a penetrating aortic ulcer on different phases of CT contrast imaging is paramount, as a lot of patients are identified during CT scans performed with intent to rule out pulmonary embolus. These images are taken from a 62-year-old male with interscapular pain. The panel in the upper left is a contrast-enhanced CT scan highlighting a penetrating aortic ulcer, as illustrated with an asterisk, as well as periaortic hematoma as evidenced by the white arrows. In the upper right panel is a transesophageal echocardiogram of the aortic arch. This once again shows the penetrating aortic ulcer and is as denoted by an asterisk. On the bottom is a TEE picture with the dark arrows revealing flow outside the lumen of the aortic arch and hence impending rupture of this ulcer. Because of their rare nature, the treatment for penetrating aortic ulcers is not well delineated. Unrelenting pain or impending rupture is absolute indications in most everyone's viewpoint. Impending rupture is defined as one which symptomatic pain with periaortic hematoma formation, hemorrhagic pleural effusion, conscious extravasation outside the adventitial wall, or a rapid growth of a pseudoaneurysm. Majority of the literature favors operative repair of any ulcer involving the ascending aorta as well as that involving the aortic arch. The rest of the indications, namely refractory or recurrent symptoms, penetration through the aortic wall, aortic diameter expansion, the size and both diameter and depth of the ulcer, and whether or not it's associated with a saccular aneurysm, have all been argued to be relative indications for repair, regardless of the site of the ulceration. A frequently cited paper on the size criteria for intervention was published in 2002. It was a retrospective analysis of 65 asymptomatic patients with an intramural hematoma with and without a penetrating aortic ulcer who were followed with serial imaging. Group 1 was divided into patients with an intramural hematoma and a penetrating aortic ulcer, and Group 2 was divided into patients with an intramural hematoma without a penetrating aortic ulcer. It concluded that patients with an intramural hematoma associated with a penetrating aortic ulcer were more prone to have progressive disease course as opposed to patients with an intramural hematoma without a penetrating aortic ulcer. Further subdividing the group with the intramural hematoma and penetrating aortic ulcer, analysis showed that those who progressed tended to have disease involving the ascending aorta, the aortic arch, or the proximal descending aorta. In addition, lesions that were greater than 2 centimeters in diameter or had a depth greater than 1 centimeter were more likely to progress. As such, the treatment paradigm of repairing involvement of any penetrating aortic ulcer in the ascending aorta or the arch of the aorta was advocated. In addition, any patients with a large ulcer mandated repair. Looking at the descending thoracic aorta, however, a different algorithm has been suggested for acute penetrating aortic ulcers. In the case of the acute penetrating aortic ulcer that is symptomatic, if there's any evidence of hemodynamic instability, signs of impending rupture, or an aortic diameter greater than 5.5 centimeters, a stent graft repair has been advocated. In this other subset of patients where they have hemodynamic stability with no signs of impending rupture, serial imaging during hospitalization is warranted. If these images are stable, patient is then discharged with plans of follow-up. Follow-up consists of either a CT scan or an MRI at 1, 3, 6, and 12 months after discharge, then annually thereafter. If during this period of follow-up the aortic diameter increases greater than 10 millimeters per year, or there's recurrent thoracic pain, or the aortic diameter increases greater than 5.5 centimeters, then stent graft repair should be considered. If during follow-up, however, there is no recurrent pain and the aortic diameter does not reach a level greater than 5.5 centimeters, then continued medical therapy with yearly imaging follow-up is advocated. This slide shows a patient treated with the previous algorithm. Panel A is a contrast-enhanced CT scan reconstruction illustrating the presence of 3 simultaneous penetrating aortic ulcers affecting the descending thoracic aorta, as highlighted by the 3 solid arrows. This patient underwent endovascular stent graft repair, with panel B showing a contrast-enhanced CT scan 3 months after the procedure. Note complete resolution of the 3 ulcers that were identified on panel A. The proposed algorithm and previous stent graft are all based on a single center experience with penetrating aortic ulcers of the descending thoracic aorta. This involved 19 patients treated via endovascular stent grafting with a mean age of 72 plus or minus 7 years for a median follow-up of 22 months. The outcomes here show that the overall survival of patients using this algorithm was 89% at 30 days, 83% at 1 year, 72% at 3 years, and 67% at 5 years. The actuarial freedom from endoleaks was 94% at 1 month, 88% at 3 months, and 81% at 1, 2, and 5 years post-procedure. A similar group of patients undergoing endovascular treatment of their descending thoracic penetrating aortic ulcers was reported from Spain. 22 patients with penetrating aortic ulcers underwent stent graft repairs with a mean age of 70 years with a mean follow-up of 52 months. Their mortality at 30-day post-repair was 4.5% and an all-cause mortality of 39% at 100 months of follow-up. The graph on the left, represented here, shows the cumulative complication-free survival of 62% at 100 months, and the graph on the right illustrates a reintervention-free cumulative survival of 80% at 100 months. The authors from the previous outcomes performed further analysis looking at their in-hospital morbidity and mortality and found an average hospital stay of 3 days with a complication rate of 27%. The most common complication was the need for in-hospital reintervention as well as pulmonary complications including a mortality, secondary postoperative aspiration, and resultant respiratory failure. In their midterm follow-up, there was no further need for intervention, with only 1 patient undergoing stent migration. The aortic reinterventions that were necessary included covering the left subclavian artery in 1 patient and repair of a pseudaneurysm caused by a puncture site in another. In conclusion, we hope that this talk was able to clear some of the confusion regarding penetrating aortic ulcers. Penetrating aortic ulcers are a rare disorder along the spectrum of acute aortic syndromes. Most studies have been retrospective in nature and have concentrated on their clinical radiographical natural history. Because of increasing sensitivity of modern imaging modalities, the incidence with which penetrating aortic ulcers are being diagnosed is increasing, as is resurgence in interest on this topic. Currently, there are no rigid guidelines for the treatment of penetrating aortic ulcers. The majority of the literature, however, does recommend the following. If a penetrating aortic ulcer is found in the ascending aorta or the arch of the aorta, they should undergo open repair because of their propensity to progress to a potentially lethal condition. Penetrating aortic ulcers of the descending thoracic aorta, which are far more common, can be treated based on clinical and radiographical evidence. Any penetrating aortic ulcer that has relentless or recurrent symptoms should undergo repair. any penetrating aortic ulcer that shows evidence of impending rupture, such as symptoms with a periaortic hematoma, hemorrhagic pleural effusion, contrast extravasation outside the adventitial wall, or rapid growth of a pseudoaneurysm should be considered for repair. Any patient with an ulcer associated with an aortic diameter greater than 5.5 centimeters, or an ulcer greater than 2 centimeters in size, or greater than 1 centimeter in depth, should be considered for repair. For patients that do not have these criteria, close follow-up with serial imaging is recommended, with treatment being reserved for those in whom the aorta enlarges to greater than 5.5 centimeters, or has a growth exceeding 1 centimeter per year, or has recurrent chest pain. Finally, endovascular stent grafting appears to be a feasible option in these patients with descending thoracic aortic ulcers. These patients are often elderly. However, there should be caution as no long-term follow-up is currently available.